So thanks for meeting with me today, Katie. I'm really looking forward to this conversation because I've known you for a little while, but I don't know your backstory. I don't know what inspired you to become a psychologist.
Hmm.
So shall we start there? Like, where did your interest first come from?
Absolutely. I was thinking about this a little bit before we met, and I thought, where did it come from? And I could only say that I'm naturally, like, just curious, just a curious person. And certainly when it came to choosing A levels, I picked things that I thought sounded interesting. So I chose psychology A level, and I think that's probably where it started. That's what gave me the bug. And I actually, when I went to uni to do my undergrad, I picked a criminology module as well. And I started thinking along the lines of, oh, just like fascinated, like why do people do what they do, especially like serial killers, psychopaths. And I thought I want to do forensic psychology, actually. That was
Right.
my original plan. But then over the years, just doing different jobs, getting different types of experience. I don't even really remember how clinical psychology came into it, but I just kind of fell onto that path, and that's where I've ended up.
So if I slow you down a little bit or take you back through that, what
Yeah.
were some of those jobs you were doing? Was that sort of during your degree or afterwards?
During my degree, I worked in an insolvency practice, which is random, but that's where it's just where my sister worked, and she got me like an office junior job. I think at that point I thought I don't want a job that's just office based and just sitting paperwork wise. I knew that I wanted to spend time around people more and talking to people and being a bit more active. Um, but yeah, it was just after my first degree, I had my first baby. So I was just looking for opportunities to kind of dip my toe in again. And I started off volunteering with the Stroke Association,
Right.
facilitating groups for people with aphasia who had problems with language and communication. And then I think the bulk of my job experience after then was support work, working with people with brain injury, learning disabilities in the community, in their homes, lots of sort of long hours, spending time with people, helping them out in all sorts of different ways.
Yeah.
And that I think that was key. I know when people think about coming into psychology, clinical psychology, they're often kind of wanting to go straight into like assistant psychologist jobs. And I know that that's really tough. Like it was really tough back when I was looking for those types of roles. But the support work, I think, was just the time that I got to learn how to be around people with all sorts of difficulties. So that was sort of the cornerstone, really, I would say, if that was
Yeah.
valuable time spent, and it was really rewarding and worthwhile.
I did the same actually, worked on psychiatric wards,
Hmm.
worked with people with dementia. And again, it was that, like you said, that learning to be with people.
Mm.
And on the wards, I remember like when families would come and visit as well, kind of
Yeah,
understanding some of their worries they had about their loved one. Um,
absolutely.
yeah, really, really useful. And then did you go straight from support work onto clinical training? What was that process like for
No,
you?
I didn't. I took a long time, partly because I was taking my time and I had a little child. Partly because I just, yeah, I wanted to get a breadth of experience, and partly because the doctorate application was so competitive. I think it took about 3 or 4 times applying before I actually got a place, and that was fine because with hindsight, I thought actually I feel more prepared coming into training. I'd done a lot of support work, similar to what you said. I worked in a secure hospital. I worked with people with brain injury in their homes. I did absolutely all sorts. It was really good part of my career, actually. There was, I suppose, less responsibility, and I got to spend all of my time alongside people. So I really enjoyed that. I took a lot from it. And because it was quite, I'm just trying to think how many years between my first degree and then doing the doctorate. It might have been 7 or 8 years or longer, actually. So I got a chance to do a few different assistant psychologist jobs. I worked in the private sector with children in care. I worked in an older adults community mental health team. I did all sorts. I did a couple of research assistant posts again, just because it sounded interesting, and I thought getting experience in the research world again would help me in terms of preparing for if I did get a place on clinical training. So I worked in prisons with University of Manchester. I worked in Liverpool, in a neuropsychology department. So all of that, like collectively, I just think it really, looking back, I'm really glad that I did that before I
Yeah.
started training. I think if I'd have come into training sooner, I would have felt less prepared, if that makes
Mm,
sense.
mm,
I know going on to placements in my cohort, some of us had less direct contact working with people or less experience as clinically or as an assistant. And for them, placements were quite daunting, and I felt as comfortable, like fairly comfortable going into placement, and also in terms of research assignments and things. I just think that taking my time and taking what I could and sort of enjoying the time that I had before training was the right thing for me. Looking
yeah.
back.
Yeah. And then do you mind me asking what it was like training with a little one? Because, certainly on my cohort, there were maybe two people
Mhm.
that had young families. And at that time, I think it was almost unheard of anybody doing the course part time.
Yeah.
Um, and one of my friends took a break partway through the
Yeah.
course and had her second and then came back and finished it off. So, yes, I'm curious what that was like.
Yeah, I remember there were quite a few people actually that had either gone, they were letting people go to part-time, or yeah, people got pregnant during training. For me, my daughter was, she might, like I said, she might have been 8 or 9 by this point, but that meant I stayed full time, and it actually meant that I was just so boundaried with my work because I only had the time that she'd gone, time that I was in uni and study days. I really just had to make super good use of them. And I
Yeah,
did a good job with that. When I was not at uni and when I was not on a study day, it was weekend and I was with my family. So I think if anything, it just made me be really organised. I think my mum skills of, planning, organising and just, yeah, making sure things get done was an advantage.
yeah,
Which
that's
might
that's
sound
really
odd,
cool
but
to
it,
hear.
it worked really well
Yeah,
for me.
yeah. Well, I remember sort of like, so it was one of my best friends in my sort of training cohort was, yeah, had a baby already when she started the course, took a
Mm.
break and had another one.
Mhm.
Um, she would have been one of the older trainees. I was the youngest on our course.
Oh yeah.
And I remember sort of thinking of like, this is a bit funny that like we really bonded. And I think it was, I really loved hanging out with her because she wasn't taking the course too seriously. She wasn't spending her kind of entire weekends writing essays. And I loved that. I loved that energy. Where for some people, it really felt like it took over their whole lives.
Yeah.
And it is hard, I know you're always a very positive person, and I know that you will have had your moments when it might have felt overwhelming and you might have wondered what on earth you were doing. Um, but yeah, that ability to keep the boundaries
Mm.
would be so helpful.
Yeah, by no means am I saying it was easy in any way, just to get that point across. It's a tough course, isn't it? It's really demanding, but yeah,
Mm.
it was just good that I was forced to keep my time on it separate from
Mm.
my family time. And I think I would be the kind of person, and many of my friends were actually on training, where you'd have a study day, but you wouldn't make the best. I don't think I would have made best use of it, and it would have spilled into Saturday. And I think that yeah wouldn't have been as helpful for me. So it worked. It worked out really well that I had other responsibilities that I had to be focused. Um, but yeah, it's a slog, isn't it? The 3 years. It's a really tough, puts you through the grinder sort of course, but it's also, yeah, an awesome and privileged thing to be able to do.
Yeah. And then if we do a little overview of what you've done since, um,
Mm.
what have been the different jobs that you'so
So I qualified in 2019 and I always thought I either want to work with adults in a like community mental health team, or my other sort of interest was because I did a specialist placement working in a alongside the local authority in children's social care. So I thought looked after children or adults like complex mental health
Hmm.
work. And in the end, I went into an adult CMHT local to me, which I just loved. I loved it so much that I stayed for 5 years. Um, and yeah, I think after that, like, they were a fantastic team. I loved the kind of work that we were doing. I trained in EMDR and in CAT, Cognitive Analytic Therapy, during my time there. I had another baby, so minus a year out of that, and reached a point where I just thought, I love this work. Um, it's good. It's quite a stressful type of work. There can be, pressures around um, risk management, and a lot of the work that we were doing as in the psychology team was trauma therapy, which is where the bulk of my experience is. But over time, I just thought, I think I just want to try something completely different and just switch things up. So I made a really tough decision about leaving because everything was, yeah, I loved being there and working with that team. But I thought,
Can I
yeah,
pause you before you talk about your moving on? I'm just
yeah.
thinking for people listening to get a bit more of a sense maybe of
Of
who your
what?
clients might be in a
Yes,
CMHT.
sure.
So you talked about obviously people with kind of risky presentations. So
Yeah.
predominantly risk of harm to self.
Risk of harm to self, sometimes to others. Um, I think in terms of mental health services in our country, if somebody is accessing a community mental health team, then they've got multiple and complex needs. So they might need psychology input, but also usually psychiatrists. So they may be taking prescribe some sort of medication. They might need input from an occupational therapist. There's always nursing staff that the key workers for people. It's really working in a coordinated team, working alongside colleagues from different disciplines. So that's why it was really interesting work. And the people it was a really wide variety. It wasn't just one type of issue that people would come with. So they might, in the NHS, they call it severe and enduring mental health. But for me, that just means people experiencing a lot of distress related to, a lot of the time that might be related to past experiences and trauma. They might attract diagnostic labels such as personality disorder. Again, it's a terminology that's used in psychiatry. It's not something that I would necessarily endorse just because of, what that can do to somebody in terms of stigma that they experience around it. But there might be people with anxiety of all sorts, obsessive compulsive disorder, depression. But our job as psychologists really is not to ignore the diagnosis, but we're just sitting with a person and trying to really understand what is happening for them, what's happened to them, um, how does that present for them, how does it affect their life, and then figure out a way together that might be helpful in terms of moving forward.
Yeah, brilliant.
Yeah,
Thank
all
you.
sorts. Post-traumatic stress disorder, complex
Mm.
PTSD, which might fit better, I think, for some people, rather than a personality disorder label.
Yeah, yeah. So that would be referring to people that have experienced attachment trauma,
Mhm.
perhaps abuse or neglect in childhood.
Yeah, and
Um,
things that are still going on within the present day. People are
yeah,
living with trauma
yeah.
still.
So thank you. I'm sure that will help people get a bit more of a sense of
Yeah.
the CMHT kind of setting. And then did you move on to the job that I know you do now, or was there something else in between?
I did, yeah. So it was
Yeah.
about a year and a bit ago, when I said I was looking for something different. I thought, right, let's just start having a feel about what's out there. And saw a job advertised it's an NHS service, but it's called the Northern Gambling Service. So we cover the whole of the north of England. And I'd caught wind of this service. I think maybe when they set up in 2019, I just came across them, and I remember at the time being like, "Oh, what's that all about?" So when I saw this job being advertised, I thought, right, okay, let's have a see what that's about. And thankfully, they offered me a job. So what I do, I mean, there's some overlap, if I'm honest, now working with people who are experiencing gambling related harm. So people primarily come to us because they're struggling with gambling behaviour in one way or another. You might call it gambling addiction, but to call it that kind of ignores all of the contextual factors because it's not necessarily just about that person having an addiction. There are lots and lots of commercial determinants, other things that kind of contribute to why people struggle with gambling, and I can talk a little bit about that. But just thinking about the overlap part, I still get to do EMDR work. I still get to do CAT work with people. Um, we might help somebody with their gambling behaviour by using our main intervention, which is cognitive behavioural therapy, CBT for gambling. So that's the kind of the evidence-based treatment that we offer for gambling
Mhm.
harms. But then often we find that actually when we've helped somebody to stop gambling, there might be some difficulties that still exist. And if we weren't to offer, support or intervention around that, the risk of them relapsing back into gambling might be high.
Excuse me.
Bless you.
Mhm.
So yeah, at that point we can think about what else might somebody need, what's going to help them to stay in recovery. So that's where that kind of work would come in as well.
Yeah.
Um,
So many directions, so many different things I want to ask you about. Let's go first with, what does CBT for gambling look like?
Okay, so that's a good question. So it tends to be we try to promote people attending it in a group format for starters because they get the experience of being around people who have lived experience, who really sort of get it in a way that as practitioners, whilst we can understand the theory, we may have some personal experience, but on the whole, it's just so helpful for people to be around somebody who's had a similar experience. And that's the feedback we get that people are like, wow, it was just so good to be, to know that I'm not on my own, that I'm not the only person that this is happening to, because that's a really common thing. People think something about me, it's my problem, I'm weak, why can't I just stop? Why can't I control it? So the CBT group it's 8 sessions and it's really thinking about how much detail do you want me to go into? I'll just do a little overview, shall
Yeah,
I?
a little overview would be good. And yeah, sort of assuming that people don't know anything about
They don't,
CBT
yeah, okay.
already.
Yeah.
So
So
yeah,
CBT, I mean, this is a very sort of basic summary, but if you
perfect.
think about the relationship between thoughts, feelings, and behaviour, it uses that model. It's a common model used across mental health issues of all sorts. But in the context of gambling, it's very, as you would hope, gambling centric. So we're really thinking about what are the triggers in the environment or internal to somebody. What is it that actually starts somebody off thinking about gambling or experiencing urges or cravings to gamble? We think about the C of CBT is cognitive, so there's an emphasis on the gambling related thoughts and how do we respond to those. It's a behavioural intervention in that we certainly think about when gambling stops, what do we put in place to make sure that somebody can continue to live a meaningful life? Um, and we also, strategies to help people manage the sort of bodily and emotional implications of experiencing gambling harm. So that might be things around coping skills to manage urges and cravings, um, and I guess an important psychoeducational component. So one is to just help somebody to understand what is happening in the brain when we gamble. How does it influence pathways in the brain, and how that can actually repair and change and go back to the way that it was before with abstinence from gambling. Um, and helping people to understand that recovery isn't a linear process. You don't just stop and then it just goes down, everything's fine. A lot of people go through what we would call a lapse or maybe even a relapse where they go back to gambling temporarily. So we just want to really help people to understand that if that happens, this is what we can do, this is what we can learn from it. And a big part of it is relapse prevention as well. So towards the end, we'll always think, what have we taken from the intervention? What do you need to keep doing going forwards?
Yeah, awesome. And then the sort of the underlying issues are things that you might help someone on to work on as they're perhaps, yeah, they've done some work on their gambling. Could you give some
Mhm.
examples of what those sort of issues might
Yeah,
be?
absolutely. So for some people, if we think about trying to understand why they started gambling in the first place, their formulation, how we might perceive that. For some people, they've started gambling, and because of the way that gambling products are designed, they're absolutely designed to be addictive, to exploit the pathways in our brain, to make it feel rewarding, to make us want to go back. So for some of those people, the CBT for gambling works is really effective, and that's it. They're
Mhm.
fine. For other people, however, like a very common example is if somebody has adverse childhood experiences or trauma of any kind in their life at some point. Some types of gambling, in particular online slots and these very fast-paced, immersive kinds of gambling products, they serve a function of helping somebody to cope, if that makes sense. So whatever
Mhm.
the distress was before gambling, gambling acts as a coping strategy. It helps me to
Yeah.
not feel bad. It helps me to avoid thinking about that. It helps me to escape temporarily.
Mhm.
So in that context, it might be whilst we can help somebody to stop gambling, we also need to think, how do we help them to develop some alternative coping strategies? Or again, for some, it might be that they undergo trauma therapy of some sort because
Mhm.
that was at the root of it in the first place, if that
Yeah.
makes sense.
So if we can resolve whatever was causing the distress that someone was experiencing, that the gambling was then distracting them from,
Mhm.
um,
Then
then
that's,
they're less likely to need to gamble. Yeah.
feels like an important thing to do. We don't just want to help somebody to stop and then leave it at that. And we have a lot of practitioners in our team, CBT therapists, so we work with all sorts of common mental health difficulties, panic, anxiety of all descriptions, depression, and then yeah, trauma work.
Yeah.
Lots of things really. It kind of there's no real limit to that, I guess, unless there was a circumstance where we thought another service would be much better placed to offer that.
Yeah. Yeah. It always surprises me sort of how two different services can look like, when we first think about it, we'll imagine that they've got very different populations, they're doing very different kinds of work. And then we learn a bit more about them and we see these huge areas of overlap, don't we?
Absolutely, yeah.
Um, yeah. So obviously in your team, you've got a gambling lens,
Yeah,
but some of the work is potentially very similar to what you'd have been doing in the
yeah,
CMHT.
absolutely. It is. And I like that about my job because I get to do, it's really rewarding working with people who've experienced gambling harms. I think like helping them to understand that it's not actually their choice, their fault, that the products are designed to exploit them and yeah, help to reduce some of the guilt and shame around that. And when people are in the right place to do the work and they do it, they tend to have really good results, and that's just a real honor to see. People put the work in and then they manage to become gamble free. The harms is just incredible that are associated with gambling for lots of people. So to see somebody come out of that, come away from it, and get help with all of the other things that have come along with it, debt and relationship problems. It's really wonderful to be
Yeah.
able to witness that.
I was just going to ask about that actually, about the financial side of that, and whether you've got kind of people in your team that help people with
Mm.
debts they might have built up, or whether you have links with other services.
Yeah, we've links. So we signpost people. We don't have people,
Mhm.
debt workers in the team specifically, but there's a national charity called Step Change who do some awesome work with people. So yeah, we'd refer them or signpost people to them, and lots of our clients will access support from them to help them come up with a debt management plan or resolve some of their issues.
Yeah.
Money.
And then I also want to take you back into, you mentioned CAT, and I know from previous conversations we've had that CAT, or cognitive analytic therapy, is a big passion of yours.
It is.
I don't think I've spoken to anybody yet who's been able to sort of give a bit of an overview of that. So, like, you've
Yeah,
done such a good job, I think, of explaining CBT in a nice, straightforward way. So, put you on the spot
I'll tell you
again
a
and see
little
what
bit
you can
about
do with
cat.
CAT. Hmm?
Yeah, okay. So I guess this is the way that I would explain it to a client that I'm working with. Um, cat is an intervention that tends to last for 16 or 24 sessions, and I can say a little bit about why that might be. But in a nutshell, it's all about relationships. It's about thinking about your earlier life and the way that you were treated by other people and templates that we all develop that help us to navigate relationships. So, Kat uses pen and paper or on the computer to help somebody to map out what relationship experiences they've had and how that influences how they relate to themselves and others. From earlier experiences, we all develop patterns of coping and surviving, and the task of CAT is to describe those that were once helpful and now have become less helpful, and they are essentially the target for the work in CAT. For somebody to start, first of all, being able to describe it and understand it, reframe it compassionately, and then move on towards recognizing the patterns happening, replaying in the current day, and then discovering ways together of being able to change them.
Brilliant. So, where it's so kind of relationship focused,
Mhm.
would people typically do homework tasks like they do with CBT? You're looking at ways of encouraging behaviour change outside of sessions?
Yeah, yeah.
Yeah.
So there's a cognitive element with the C in cat again. Just thinking about the patterns tend to be, what are we trying to get to? What is the aim? What do I believe? What is the assumption that I'm making? And then, sorry, there was a lot of beeping outside then.
Oh, I didn't hear it.
Did you not? And then what are the consequences of me acting on that behaviour and how that then maintains any difficult emotions or continues to maintain the template, the relationship template. So I'll give you an example of a template.
Mm-hmm.
If I experience a lot of criticism from people when I'm growing up, I've got criticising as another at the top, and I feel criticised. I then internalize, I take it on board. This is how I expect people to behave towards me. This is how I behave. This is how I treat and behave towards myself, how I relate to myself. And I also have the capacity to do that to others. So that's a really common one, actually, criticizing to
Mm-hmm.
criticized. And yeah, in terms of homework, there is certainly a requirement for clients to do monitoring. So we would ask people to look out for this thing. Once we've developed a shared formulation in a diagram, a map, I would call it a map format, that person then starts to use that. And the aim is to just, at first, just recognizing, it's just spotting, noticing, when am I experiencing this person as being critical towards me? When am I doing this behavior that I'm saying is a bit of a problem for me now? Just coming back each week and saying to me, this is what I've noticed. We're not trying to change anything necessarily in the first instance. But when we get good at recognizing it, when I can start to clock it, it becomes more conscious. It's less emotionally driven. I become more aware that this is how I'm behaving or this is how I'm perceiving things. When we get good at that, then I can start tweaking things. And people often naturally start to veer away from those patterns. They start coming back saying, this happened, but I didn't do this thing that I normally do. Okay, so what did you do instead? So, organically, people, they come back with their own solutions often. Or sometimes we might think about bringing in some skills from a different type of therapist, how to help somebody to be more compassionate, or yeah, coming up with what we'd call exits from those patterns together, and then they go to practice those. So, in an ideal there isn't an ideal therapy, by the way, but in an ideal world, you might have someone who's got a good understanding of why they do what they do, why they feel the way they feel, how they relate to themselves and others, then they start to be able to recognize some of this stuff happening in the present, and then they can move towards change and revision of the patterns. And a key part to mention before we finish talking about CAT, because I will talk about it all day, is the A, which is the analytic. So if you think about two people in a room in a therapeutic relationship, I say to clients, it's a relationship just like any other. And in fact, it's a bit more intense because of the work that we're doing together. And some of the things on your map, they will likely come up in this room between me and you. And our job is just to notice that if it happens and be curious about it.
Mm.
So that's the analytic part of CAT, which
Yeah,
again is really, really interesting when you're using that model.
yeah. And so for you, you've got your EMDR that you're using
Mm.
people with trauma related issues.
Mhm.
Um, and then I'm curious with CAT, I'm guessing people that are experiencing difficulties in relationships, it's going to be a useful model for, but
Yeah.
also presumably with the way people might be internalizing, for example, that early criticism. I'm guessing also kind of self-esteem sorts of challenges.
Yeah.
Um,
It's what we would call trans-diagnostic, so it can be applied to almost anything because whatever you're dealing with, whatever you're struggling with, we can map that out. If it's gambling might be on there, self-harm might be on there, self-criticism might be, yeah, anything that look, it was originally developed for supporting people with interpersonal difficulties and emotional regulation problems who might fall under the category of a personality disorder diagnosis. It's been used for low self-esteem, relationship problems, lots and lots of different things. But I think most of the evidence is around people who've attracted a diagnosis of personality disorder. There's a lot of research, well, not, there's a little bit of research ongoing at the moment looking at using it with young adults and children who self-harm. Yeah.
that's taken me off. That's made me think about someone I'm working with at the moment. I need to park that. Come back to that later.
I wanted to say, Jenny, just something about you were asking about my job at the moment, and there is overlap with what I used to do in terms of you get to do some, psychology work and you get to work with people directly on gambling harms. But I think the thing that uh, I really love about the job is that it's so broad for me and varied. So when you do your clinical psychology training, you're trained to be a researcher as well. And
Mm-hmm.
I think often what people find, and I found when I finished training, that kind of it never gets dropped because you've always got a critical lens. If you're reading a research paper or something, like you're really well equipped to determine how much value should I place on this. And other things like that, just in terms of your critical reasoning. The job that I'm doing now, I get to be involved in research. So we have a journal club that I facilitate where we're looking at new research related to gambling or sometimes other things as well that we look at together as a team. And because of the way that our team's set up and the work that our clinical leads put in, we've got good links with other universities. So there's funded research projects going on using our outcome data, all the questionnaires that we give to clients throughout the treatment and at the start. So I get to be involved in all of that stuff as well as supervising other staff, CBT therapists, psychologists, assistant psychologists. We get to do. I'm a bit geeky, so I do like stuff like audits and service evaluations where you just kind of checking out how well your service is doing in a certain area, or you are, trying to measure whether or not we are doing things that we say we're going to be doing. So that kind of systematic, logical
Yeah.
is a work that I really enjoy. And we, as a whole service, in fact, across the Northwest and the Northeast, we're linked in with public health teams. So they might be people in the local authority, local councils who are working on gambling harm strategies for their areas. So we get to feed into that. And it feels really, worthwhile. I think
Yeah.
this is something that we were taught about when we were doing our training, and I was always interested in that. We could work with somebody one to one in a room doing therapy. We can work with a group of people, and we can capture more people, and we can offer a group therapy. But for me, it always felt like we're still at the other end. People have already been harmed or distressed.
Mm.
We're trying to help at that side of it and doing the upstream stuff where we're thinking about feeding into public health, like population level influences, and yeah, just helping to raise awareness and promote people in the general public being educated about things. I think that's really, really fascinating work, and it's really rewarding as well.
And unusual, I think, for a clinical
Mm,
psychology role. Um, I was talking with Alison, who you'll know, one of our associates in her health psychology role, and I think for them it's a much more common part of what they do.
mm,
Um, but yeah, I think that's really cool, isn't it? Like you say, broadening that reach.
mm,
Um, yeah.
yeah,
What would you say are the most challenging aspects of your work?
challenging. I think with all types of psychological work, I mean, there's a demand on your time. I mean, people certainly in the NHS, not always, but lots of the time, it's just such a busy environment. So it's
Mm.
yeah, there's something important about trying to keep yourself boundaried and look after yourself within that so that you're not burnt out. And I guess layered on top of that is just the type of work that we do, or the type of work that I was doing around working with trauma. Like you can carry the weight of that. It's hard to hear people's stories when things have happened to them that yeah they do it does affect you. We're just people, aren't we, and having conversations in a room with somebody, and I think that stuff stands out as being the most challenging. And thankfully we as psychologists, generally speaking, as far as I'm aware, we've got really good support in place in that we have what we call supervision, where you meet once a month with somebody who, yeah, gives you time and space to think about that stuff and yeah, just reflect on how things do affect you.
Yeah,
So I think that's probably, yeah, that stands out as the most challenging. It's just when, yeah, to hear people's stories that are
yeah, yeah,
breaking sometimes.
yeah. And I think there's something about trauma as well, isn't there? About sometimes like how visceral,
Yeah.
how vividly people can talk about it. I was talking about that in a supervision session with someone this week, and both of us kind of thinking about examples of times that clients have said something, and it's the physical response we've had to
Mm.
the awfulness of what
Mm.
clients have shared. As
Yeah.
yeah, it's been intense, been difficult.
Mm.
Um, what would your advice be for people perhaps studying psychology, wondering if they might like to be a psychologist?
Yeah. I wonder what that would be. I think it links back to what I was saying at the start. There's something I remember being like, I'm so need to get there, just really like keen, enthusiastic, like so many. We have psychology year in industry placement students in our team, and everyone that you meet is so often just brimming with enthusiasm and wanting to get ahead. And I think like really channeling that and taking your time.
Mm,
Wish somebody had said to me, do you know what? Just relax a little bit, just take your time. You'll get there at some point if you want to get there, and take from take what you can from what you're doing now. I think that would be my biggest piece of advice.
love it.
It will land you in good stead to really
Yeah,
just yeah, soak up what you can and do you know, different things. Don't put everything into psychology. Think about all the wonderful things that you can do with your time before you get on to training, traveling. These things are. It's not just assistant psychologist posts that are valuable. I get that they are highly valued by courses, but um, it's more about what you can take from everything that you're doing.
Yeah.
I think is
Nice.
wow.
Katie, is there anything we haven't talked about that you'd like to share?
Yeah, I don't think so because I just wanted to, when you asked about the gambling service, wanted to make sure that I got in there that it's just, yeah, it's a great place to be in terms of the variety and stuff. So yeah, I
Yeah.
think, yeah, I think that was it from me. Thank you
Awesome.
for
Thank you
having
very
me, though.
much. Say that again. Sorry, I talked over you.
Thank you for having me. It's good
Oh,
to see you.
it's going to be a big thank you fest now, isn't it? But no, thank you for coming. I'm gonna pause the recording now.